The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Welcome to today's webinar. Today we're going to be talking about addressing common team challenges. Before we get started, I just want to let you all know how we're going to take questions today. So we've got a lot of content to go through. So if you have questions as we're going through the presentation today, you can go ahead and type your questions into the question pane in GoToWebinar. I'll organize those and then I'll ask those aloud to our presenters. So no need to wait till we stop for questions. You can just type away as we're going through things and as questions come to you, and we'll address them as time allows at the end of the presentation today. Before we get started, I'm going to tell you a little bit more about the Institute. The Institute is a public-private partnership that launched late last year to offer a broad array of technical assistance to practices working on primary care transformation in Oregon, and specifically aligned with the PC-PCH model of care, which is the way the state recognizes primary care homes. We are running a series of learning collaboratives, and we have a website and webinars and online learning that is in development that you can access at www.pcpci.org. And I'm going to go ahead and turn things over to our presenter today. So we have a couple of different presenters who are going to share some great information with you. The first is Dr. Ron Stock, who's an associate professor of family medicine at OHSU. We're very lucky to have such a great local resource and expertise around team-based care and teamwork and how you measure and improve it. And then we've also invited some guests from the Providence Medical Group Southeast Family Medicine team to talk to us a little bit about their experience in working on teamwork and team-based care. So I'll go ahead and turn things over to Dr. Stock.
Great. Thanks, Kate, and welcome to everyone for really part two of what's hopefully more discussion about how to improve and create teams in our practices. What I'd like to do this afternoon is first of all, review a little bit about what we talked about in the first part of the webinars about a month ago. And that'll be very brief, but I really want to get into talking about what I think are the key strategies, key areas of strategies to really make teams more highly effective and efficient, really taking them from good teams to really great teams. And the 5 general areas that I want to cover this afternoon really fall into, one, really developing team structure and function and what that looks like as an infrastructure. Secondly, I want to talk about standard work and the processes that we are a part of as we go through our practice. Third, we know that communication is a key piece to developing strong teams. Fourth is an emerging idea about how can we become more motivated to be and more satisfied in practice. How can we bring joy to the practice and how that leads to better teamwork. And then finally, integrating patients and families, and I would say maybe even communities into our practices and how that can really promote teams. I can imagine that maybe many of you have already gone down the road here of improving your teams and using some of the techniques and strategies that I'll talk about this afternoon. But hopefully it will be maybe some other ideas and maybe generate some discussion at the end. What I'd like to do today also is do something a little bit different, and that is I'm going to bring in a practice that's been working at becoming a medical home, and really get them to reflect on some of these 5 areas and report back to you about how what kinds of things have worked well for them and what some of the challenges are, so that we begin to ground this in the real day-to-day life of practicing. Just to remind you that last time we talked about defining team-based care, and this is the definition from the Institute of Medicine. There was a group of us that met this past year and developed a white paper on what team-based care is all about, what are the key attributes of the team, and I encourage you all to go back and look at that manuscript. It really talks about what I call the 3 C's, and the first C being that of collaboration. Bringing people in the room, bringing people in the practice and that begin to collaborate together, that they also then begin to communicate, the second C. and through communication and collaboration, it's only then can you begin to coordinate, which is the third C. And I've more recently thought that I might add a fourth C to that, and that is continuous learning. I think that teams that are really highly effective and efficient are continuously learning about how they can improve. The second part too that we talked about last time are the idea of mental images and the importance of your staff and your practices to really think about what it is to be a team. And so we talked a little bit about using orchestras or symphonies and using teams as a way to begin to engage your own staff to think about what are the good attributes of good symphonies and good teams, and how that can then be translated and generalized over to good practices. We know that we all play maybe our own instrument, but that a great symphony is more than just the individual instrument, but it's everybody listening, playing off the same music that creates the beautiful sound that we hear. We also know that we need to have conductors and people that lead the different instruments, and that it generally requires a lot of practice, and that sometimes even in medicine we don't practice as much as we could be, but that good sports teams and good symphonies practice a lot. And so we found that this is a good way to introduce teams to your practice. We also talked last time about distinguishing between teamwork and team-based care. Teamwork really being the relationships, how we communicate, how we interact with each other is really important within practice. And the team-based care is really the specific approach to delivering health care that really requires that teamwork, requires relationships, but it also requires us to begin to have communication with each other around what are the protocols and processes that lead to better care. And then finally, we talked a bit about the teamwork model, and that the individual member, the team itself, and the organization all share responsibility for developing a lean, efficient, and effective way to deliver care. That inattention or over-attention to one of these components is really not sufficient to optimize the team. That if we just focus on a workshop for a team that is not followed up by good support from the organization, that we're not likely to be effective. We also know that each of us comes to a team with our own individual skills and behaviors, and that training somebody to be a team member and putting them in the room doesn't necessarily make a team. That the team itself has its own attributes and its own ability to function as a group of people. So getting started, let's move forward with what we want to cover this afternoon. And the first strategy or topic that I'd like to discuss is really how to be deliberate about building a team infrastructure. And who's on that team? I would speculate that most of your practices, that most of the folks are participants or members of multiple teams. So when I think about a practice that might have 4 or 5 clinicians, that there may be many receptionists or patient access specialists, nurses, receptionists, care managers, whatever, and that would potentially be one large team. But that I would speculate that also the nurses probably meet together, or the clinicians, or the patient access specialists, that they may also feel like they are members of the team. There may also be may likely have a quality improvement team, and so that folks are members of multiple teams. And I think the important point here is that do folks know what team they're actually on, and is that well defined? And so I would encourage you, as you think about that practice, that if I were to ask anybody in your practice what team are they on, that they should be able to tell me exactly who they are and what their role is on that particular team. A question I get frequently is, well, what's the optimal size of a team? And I just wanted to make a comment about that. I think that a lot of the literature talks about anywhere from 5 to 8 people on a team. But when you think about a smaller team of a clinician and a nurse and a receptionist, they may huddle together once or twice a day. But that's really a small team, and it certainly has the advantages of being quite nimble in terms of being able to make some changes. But what it lacks is that you may not have the diversity of opinion, diversity of thought that really larger teams can bring to the table. And so then many times you really need both or multiple teams and really to be effective. And then to ask a question about, well, how do they interact with each other? One of the ideas that has emerged as a positive aspect of teams is the ability to co-locate and to put people together of multiple disciplines all in the same room together, and that really leads to an improved team infrastructure. The idea of huddles, of meeting before each clinic to discuss patient care, and the idea of meeting on a regular basis as a larger group are all important ways in which you can develop the team. Of course, one of the questions you need to ask, what are the key roles? Certainly leadership is critical, that during team meetings and huddles, you may have different roles. The nurse may play a different role. There may be shared leadership. There may be sharing of roles. Someone may keep time at different times, at different meetings. But what do you do, or what do you talk about when you meet? And I like to put these into sort of three general categories. One is around patient care. I think that the most benefit that teams get are when they talk about teams within the context of patients, and where they're actually working on improving the care of patients and how they can work together. So I think that that's an important part of team meetings, certainly huddles. That's very important. The second part is operations. How do you actually improve the workflow, continuously discussing that in meetings and improving that? And then thirdly, quality improvement, providing feedback to the team about about how they're doing with the quality measures or process measures. So thinking about what do you talk about, how do you manage the agenda, these are three general areas. But I would also like to emphasize that I think most teams develop better when you do this within the context of patient care. One of the questions that frequently comes up is how do you know that you're actually achieving what you're aiming to achieve? And so I call this developing sensing systems within the practice. And I think it's important to be deliberate about what are the measures or the sensing systems that you've put in place to measure whether your team is accomplishing what it's aimed to accomplish or not. Last time we talked about the team development measure, using this as a way to measure the amount of teamwork within the practice, the amount of teamness, if you will. We are about ready to publish this. It's been accepted for publication, but right now you can access this measure at the www.teammeasure.org to get that measure. But using that and providing feedback to the team and letting them discuss how they might improve their teamwork is one way in which you can use that as a sensing system. The other are using, having a standard set or a dashboard, if you will, of process and quality outcome measures. It may be processes within the office like phone abandonment rate, or the amount of time it takes that a patient is in the practice from the time they enter reception to the time they leave the office. A number of quality measures, maybe your diabetes measures, maybe your patient satisfaction, but that you actually have a set of measures that you use as a sensing system about whether you're really accomplishing what you need to accomplish. I think it's important that teams be deliberate about setting time aside for reflection. I'm going to talk a little bit more about that a little bit later as we talk about joy in practice, but I wanted to emphasize it here. And then finally, there are some team issues, that there are issues and questions that come up. For example, what if someone doesn't want to be a team member? What do you do with them? And can you actually be a team if there are clinicians or staff people who don't want to be on teams? Changes in membership. What happens in your team when somebody comes in as a new player after maybe many of you have been there for years? What happens when somebody leaves? Do you have a standard process about how to manage the coming and going of membership within the team? And then finally, frequently a question is, can we really afford to do this? Can we afford to meet? What's the financial implications of meeting for doing a team meeting once a month or every other week? And I usually ask the questions, I'm not sure, can you afford not to do this, in terms of the importance of communication, importance of feedback, and the improvement of quality of care when that happens. Some of the most rewarding and satisfying moments in my practice through the years has been when everything has gone right. And I think that examples of this, at least in my experience, has been the well child check. That when I walked into the office, all the forms have been filled out, the immunizations are up to date. The diabetic patient who I walk in the office, their shoes are on, socks are off. They've already been tested for peripheral neuropathy. All of their numbers, everything is listed, and the patient is ready there for me to have a conversation with them. The patient who has already been asked that whether they've been up to date with their Pneumovax vaccine. And I didn't have to tell anybody because we already had standing orders that they received the Pneumovax, and it just happened, and I could be dependent on my staff to do that. But doing that, it really requires you to think through what the process is, and that it doesn't happen by itself, but it happens through what we call standard work. And that one of the tools to get to standard work is to begin to deliberately think about what is it that you're trying to accomplish. And then to use a process mapping mechanism and flow charting to go through the process of understanding what that flow is. And there's an example there of a flow chart. I would just say that probably the going to sleep, I'd probably have a circle there rather than a square, because the circle of on a flow chart is usually the indication that that's the first step. And so there are this is really a good way to understand the process of virtually anything that can happen in the practice. I believe that we'll be having some documents that will be present that they'll walk you through doing process mapping. I think it's really a great way to begin to understand and to promote team building in practice. And I provide some process steps here. But what I want to point out is further down the line there, after you've gone through a high level as is, this is the way it's currently happening in the practice, and this is the way we'd like to happen in practice, that you ask yourself about, well, where does the patient have problems? Again, coming back to doing this work within the context of patient care, but asking yourself about where that's at. So how does this build teams? Well, it really reveals the whole process, and it gets everybody on the same page. By integrating stakeholders into the process, the staff begin to feel empowered. They begin to be part of the process and also part of the solution to the process. Working through a process mapping also allows you to begin to see where there's waste in the system, that there's duplication. There may be duplication of roles and duplication of jobs that you hadn't seen before. There may be a lot of variation, and that through variation there may be some risks that can be mitigated through a more standard process. You might find some unnecessary steps. You're putting a chart number on a piece of paper which you don't really need to, and nobody actually is looking at that. So you begin to eliminate steps that produces a more efficient process. And then finally, the roles and goals get defined. And for staff, this becomes really important to understand what their role is in that process and what they need to do. And I might add that one of the advantages with this is that as membership changes, you can have members change, but the process stays the same. And it also allows you to provide a process to people who may be coming in new to the practice and allowing you to train them more efficiently and effectively into the practice. So I'm going to stop there just we covered 2 of the 5 strategies so far. And I'd like to take a moment here, and I'm going to ask the staff out at Providence Southeast Family Medicine, who I'm very grateful to this afternoon, to provide us a little feedback about and reflection on the 2 strategies that I've just been talking a little bit about, and to share with us for a few minutes what's worked well and what's been a challenge for them. And maybe they could first start off by just telling us a little bit about your clinic. So I'm going to turn it over to Providence Family Medicine.
Hi, my name is Charlotte Navarre. I'm a registered nurse. I thought I would tell you a little bit about our clinic before talking a bit more about my role. Southeast Family Medicine is a teaching clinic, and we're one of two primary care clinics with the Providence, Oregon Family Medicine Residency Program. We're a state of Oregon recognized Tier 3 patient-centered medical home, and we're also part of the Comprehensive Primary Care Initiative through CMS. We have 7 faculty physicians, 9 residents, and 2 advanced practice providers seeing patients. And as part of the extended care team, we also have integrated behavioral health, prenatal case management, a pharmacist, a community support worker, a case manager, and 2 RNs. Our patient population, we see a little over 6,000 patients at our clinic. Payer mix is 40% Medicaid, 10% uninsured, and the rest are a mix of Medicare and commercial. Our patients come from all over the world and immigrate to Oregon, and they speak a variety of languages, with Spanish, Russian, and Cantonese being the most common. Our staff also speaks Spanish and Russian and a couple of other languages. So that's who we are. My role in the clinic is part of the leadership team that's been implementing our team-based care and our primary care medical home. I'm a faculty member with a background in behavioral health, but I've been with this clinic since 1998 in a variety of roles, so I understand how the clinic works.
And my name is Anna Marie Proctor, and I'm one of the team leads for Care Team 3, or C, one of the changes we are making. I currently, I do like phone calls and checkout, and had a little bit of a role change there, and I'll talk more about that at another time.
Hi, this is Evan Salino. I'm a family medicine physician here at Providence Southeast Family Medicine and a faculty member of the Family Medicine Residency. Been here about a year, and I'm on the team with Anna as well.
My name is Zoila España. I'm the care coordinator and team lead for Care Team A here. I'm going to explain a little bit about our team development and staff changes. When we started this medical home model, one of the biggest changes that we made was that our front desk staff actually co-located to the back to each of our teams. We met a lot and did a lot of team structure changes, one being voting team leads for each of our teams. Each team has a team lead that we meet together once a week to go over workflows, make sure we're all doing the same thing. We also have a new role called care coordinator, which is what I do, and we're pretty much in charge of coordinating everything for the team, making sure the doctors are checking their paperwork, getting together with care homes, and making sure patients are getting the best care possible in all facets. Our team MAs are the rooming MAs, so they're the ones that actually do the patient care. And we have our providers. We're all co-located in one space. And we try as much as possible to do our one-touch whenever a patient calls in. We're all in the same room in case a provider can answer the question right then and there. I'm going to pass it off to Anna to talk about some of the challenges that came up at the beginning.
I was at the front desk at this specific clinic for almost 10 years. So when they came to me and said, we're going to move you into one of the teams, at first I took it as, oh, am I not, good enough to be at the front desk anymore? No. And in reality, it was, an honor to be moved into this team. And I did go with a little hesitation because you become comfortable in your role. But as we developed the team, and I was voted as the team lead, it was a little scary in the beginning, but as we developed it, it has been the best thing I've ever experienced. I we learned, in most clinics there's a division between the front desk staff or the people that are taking the phone calls, the medical assistants or RNs who do the rooming and assist the providers, and the providers, will all talk to each other and say hi, but there's always that clinic division of that's your role, this is my role. And moving into the team, that was one of our challenges, was learning that we're now a team and the roles weren't as defined. We were going through these gray areas of, hey, I can help you with this and you can help me with that, and we worked together more as a team. That is, it had its challenges, but we overcame them, and it's about the most amazing thing I've had in all my years here in this clinic.
That's great. Yeah, so that's great. I think that this is particularly for practices where you've had staff there for a long time. Actually changing is a huge stressor for many people, and it's also sort of walking into the unknown. And so this is a very commonly experienced challenge: is how do you begin to change your role, and then you learn about other people's roles, and being in the same place sort of forces you to be interacting with each other about that. I'm going to, in interest of time, I'm going to keep moving forward, but we're going to come back to you. Okay? We're going to have more time here to hear a little bit about some of the things that have worked well and your challenges around the next two topics, which is really the area of communication, which is we know is critical to the success of teams. And if folks remember at the last webinar, I shared with you the team development measure and some of the important findings that we discovered using that instrument. And one of the items on the instrument was one of the things we looked at is what was all the 31 items that we used to measure the amount of teamness within a practice, which of those items was the best predictor of whether there was a team there or not. And of interest, you would know that I'll remind you, but the one item that was by far the most predictive was the item that said, regardless of the topic, communication between the people on this team is direct, truthful, respectful, and positive. When teams and practices endorse that as really happening within the practice, they also have a lot of the other team attributes within the practice. So we know that communication is critical. If you were to ask staff, I think that by far staff in teams that are highly functioning, they would say that the communication between each other is critical. And I put on here, and again want to emphasize that we all come to the team with our own style of communication. And what I'm reminded of is I'm reminded of my own family, of my daughter, who won't answer her phone, but she'll answer a text within 2 seconds. That you have different ways in which people want to be communicated with, and even within a practice, you may have clinicians, you may have nurses and other staff that may want to be communicated on the spot, or they may want a note that they can follow up with. The other piece around communication is the importance of communicating between each other, particularly around conflict and tension. One of the ideas and techniques that I've used in practice in the past is what I call Valentines. As your nursing teams and clinician teams and reception teams meet together, you may have complaints about the other folks. For example, the receptionist may be tired of the docs coming in late, or the nurses may be tired of the docs running behind, and the docs are complaining about being overbooked. Well, the idea of Valentines is that instead of posting complaints, that they write a Valentine to the other group about that and what they would hope or wish to do, and that they begin this negotiating and communicating process about how they could work together to make that better. Using language and using words in a more positive sense is one way in which teams might be able to function better. One of the things that I just also want to recognize that communication is more than just between staff, but also how we communicate with patients. And that as a team, we are able to communicate with that with patients, and how we do that is important. And then finally, we need to acknowledge that a lot of our communication these days is electronic, and recognize that sometimes these handoffs that we make sometimes may be cold versus warm, and that the importance of warm handoff may really help develop the team and be more beneficial than maybe some of the cold handoffs that we make through electronic means. One of the things I want to acknowledge as a real issue in developing teams is the fact that there's always going to be conflict. So I usually, in groups when I'm actually in front of people, I usually ask people to raise their hand, all those folks that love conflict. And in a medical group, I have out of about 100, I get about a half dozen hands that come up. And then I say, well, you know, it's usually a little bit different when I'm with a group of attorneys. Virtually everybody raises their hand because that's the way they make their living. So conflict that in our profession, we tend to be a very conflict-averse culture, and we need to recognize that. And that in reality, we need to be embracing some of the tension and conflict, because it really is an essential part to team function and really maintenance. Making people feel a little bit anxious or a little uncomfortable is usually the best way to get them to change their behavior. It also leads to people thinking about innovation and problem solving. But it's important to think about, well, there are different kinds of conflict. And that we take it away sometimes from the person when we think about what the conflict really is. And I suspect that there are many leaders on this webinar today, and it really, in my opinion, is an essential part of leadership is to be able to diagnose, if you will, what kinds of conflict is occurring. Because, you know, if it's an intrapersonal, a conflict happening within someone, you need to deal with that differently than if it's something within the team, or whether it's actually between teams. Approaches to tension and conflict is important. You need to acknowledge that it's going to happen. It happens in all groups of folks, that the team begins to actually discuss what are the ways in which they would like to deal with the conflict, and that there's some understanding about how interpersonal conflict may be addressed with the manager or with one-on-one coaching from leaders, but that if there's an intra-team conflict, that the team talk about how they're going to have a discussion about that within their team meetings. But this is a really important part to developing teams. The next topic that has been an observation of myself and many others who have been involved in healthcare delivery redesign through the years, and also I discovered and written about through the National Demonstration Project of the Medical Home, is really talking about what is it that motivates people to come to work every day. What is it that gives folks a sense of meaning and satisfaction? That this is really an important part of change. It's an important part of our lives as professionals in practice. And what we've discovered is that some practices are better able to manage all the stresses of practices which are inherent in taking care of people, healthcare needs, but also to manage all the change that's happening in medicine these days. And that really the idea that some practices have adaptive reserve, or the ability to of a practice to be resilient, to bend and thrive despite being under a lot of pressure, that facilitating adaptation during times of dramatic change. I show this picture on this slide to remind me of probably a little over 10 years ago. This is a practice which I was practicing in Eugene, and a receptionist, a patient access specialist, came to our leadership group and expressed a lot of concern because many people died in our practice. As a geriatrician in a practice that was primarily geriatrics, it's one of the inherent things that happened in the practice, but that it was clear to us that this was really hard on our staff because they came to know many of these patients quite well and needed a way to express the grief that they were experiencing with that. And she had a great idea of trying to implement within our team meetings some way to acknowledge that. And so it was our job as leaders to help promote and to support that. And so the receptionist developed a process every 3 months of developing a little service of lasting about 5 or 10 minutes. And they developed this the wreath that you see behind the desk there. And each of the ribbons on that wreath has the name of a patient that's died in the practice. And so the staff would then, during these ceremonies or reflection periods, would then tie that onto the wreath, and over the years they've actually developed, I think, maybe 3 wreaths. But this is a way in which the practice begins to take care of themselves and to have what we call adaptive reserve. These are the components of adaptive reserve, but I think the important thing is really making time for reflection and allowing staff to have that period of time. The next idea that I want to present to you is an idea that is a theoretical concept that's emerged over the last 10 or 15 years called flourishing. And it comes out of a theoretical concept of positive psychology as opposed to looking at maybe the more negative parts of mental health. And it really, flourishing really is the epitome of healthy adults having high levels of emotional well-being, being happy and satisfied. They tend to see their lives as having purpose, feel some degree of mastery and accepting parts of themselves. They tend to choose, have more locus of control, and they choose their fate in life rather than feel like they're being victims of fate. And what we've discovered is that folks that have a more flourishing approach as individuals, they tend to be a healthier group of folks, both mentally and physically, but also some generalization of work that's shown that groups may also flourish better, and that the opposite of flourishing may be languishing. Some of the work done in the last half decade or so talked about how the ratio of flourishing and positive affect to negative affect really has an impact on the group, and that groups that tend to have about 3 times as many positive as negative tend to flourish more than those groups that have less positive aspects to their group. So the point I want to make here is I want you to think about your teams. I want you to think about what happens in the discussions that happen within your teams. You may even want to have somebody keep track of the positive statements and the positive things that are talked about within your team meetings to keep an idea, get an idea as to whether this is more positive or this is more negative affect that's occurring within the practice, and whether your practice is flourishing or languishing. So I'm going to ask the Providence group to reflect a little bit on what we just talked about in terms of communication and bringing joy to practice. So you want to take it from here, and I'm interested in what you think about this.
Hi, this is Anna Marie again. I would say the communication piece that we found is necessary is to have those team meetings, and we found that having them weekly works best for us. We are able to sit down, talk with each other, see what's going well, what needs improvement, and then we also do our team huddle. So each half day we meet as a team, and this is a great time to discuss what might be needed for patients. If a medical assistant or myself aren't going to be available, we can communicate with each other as a team and keep each other on board. And then also in our very first, when we first formed our teams, we as a team made ground rules that we would everybody agreed upon of how we would treat each other within our teams and how our team meetings would go. So if conflict arose, which it has, we were able to discuss with each other and go back to those ground rules of how we would treat each other, how we would listen to each other, because each person has their own way they adapt to change and their own way that they communicate. So we had to share and learn that from each other. And we did have an example where two coworkers were having conflict about what their understanding of a process was, and they were becoming frustrated with each other. And we, there was 3 of us actually, and we just took ourselves out of into an office and openly discussed that conflict with each other. And once we worked it out, we were able, we agreed, okay, we've worked it out, we're going to move past it, and it did work really well. And then I'm going to pass this on to Zoila here.
Hi, this is Zoila again. I'm going to talk about the communication on a daily basis between the clinical staff. What we decided was to come up with a magnet board. That's our main communication during the day. It's in a central place in our team areas. The magnet has all our room numbers on it and different magnets for the front desk staff that does checkout, from the clinical staff that does the clinical work, and RNs, case managers. And what happens is whenever a provider needs something for that room, they come and put that magnet for the specific person there. So if everybody knows to look at that magnet all day. If there's a red magnet, we know it's a MA that needs to go and do some care in that room. And it's worked really well. It was a challenge at the beginning to remember to look at the board and to remind the providers to always use the magnets. But now I think we really depend on that on a daily basis.
Yeah, so that's great. I love hearing it, non-electronic means of communicating, because I think we sometimes think about trying to figure out how we can get this into the computer or into the EMR or something to do it electronic, and sometimes the simpler things like a magnet board or a whiteboard or even a sheet of paper sometimes to keep track of things can work very well. That's great. What about any thoughts about bringing joy to practice?
Yeah. This is Evan Salino, and I was just going to address that. And I mean, first of all, certainly this is becoming a huge issue amongst certainly physicians, recognizing that in primary care that a lot of folks struggle with finding joy in practice, and honestly, some practices that I've worked at, that's been a struggle as well. And I think an example of where I've seen that work here, we just have put up, I don't even know whose idea it was, but we put up sheets of paper with everybody's name who's on the team on these white sheets of paper, and then team members would go on and put a little Sharpie up there, and you'd write something about that person, something that you'd appreciate about that person, and they're just hanging in a hallway here. But just seeing that happen, and that the really how folks know each other and saw the community come together, it helps motivate you to feel like, we are all on the same page working together. I like these people that I come to work with. Even though work is hard, that we are finding, really a community here. And that we can work together to overcome things. And it's really that community and fostering that helps. But that's just sort of a very small, concrete example of something that we've done the last couple of months.
Yeah, it sounds like that increases the positivity ratio a little bit by doing some of those things, even though it may not even be in the meeting, but it may actually be in the hallways or other places where you might begin to reward people and show others what others are doing. So I'm gonna. So how about a challenge? I have time for a challenge here. What's been challenging? Let's say with the maybe getting people motivated to do this work, or have there been any challenges with that?
This is Charlotte, and I can talk to that a little bit. We were most challenged, I think, as a clinic and our team structure by a conversion from our health system from one electronic medical record system to another, which we had a nice functioning one before and a lot of workflows and things built in that worked very well for us, and we moved to one that did not have that. So we were extremely challenged to come up with workarounds on things like substance abuse screening and developmental screening and MCHAT screening. So if the clinic didn't have a good working team structure, I don't think we would have survived that as well as we did. So that was one of the huge challenges I think that we faced.
That's great. So I'm going to move on, so we'll have some time at the end here for some other questions, and certainly maybe some comments from folks out there in the on the webinar, maybe questions for the Providence group, or comments about what they may be doing, what some of the challenges they are, and how they've overcome them. But what I'd like to move on next to is sort of the last strategy, and that is the idea of helping build teams. Recognizing that patients and families are important roles, play important roles on the team, and what role do they actually play? This is recognized by virtually everybody now. There's been a requirement by virtually all of the redesign teams to begin to integrate patients and families into the practice. I also, as you'll note, I put in the title also maybe integrating communities, that we sometimes don't think about them as another entity to integrate into practice, but that certainly members of the team are more than just the health practitioners, but also the patients. And that, quite frankly, I think that we have, the healthcare profession has struggled a little bit about thinking about what that role means and what that means to in the practice. And that also from people that I've talked to, I think that this is also new for patients, that the idea of thinking themselves as more consumers of what we provide for them as opposed to being partners. And I'll say that, just a comment here that I don't know that there are any solutions or a complete understanding of how to do this, or what role patients and families and communities have on practices and practice teams. And in fact, part of an Institute of Medicine task force at this very time that we've been meeting over the last 3 or 4 months, but it's a task force just on understanding patients on teams. And I think after several conference calls, we've now landed on the fact that we're going to go out and do focus groups and interviews with patients to try to understand what they think about being a member of the team. Because I think it's quite broad, and there's a lot that we don't know about this. But I do want to comment a little bit on a number of ways in which integrating patients and families into the practice can help build teams and provide some ideas for us to be more team-like and have more teamness. Certainly, many of the practices are developing patient advisory councils. This is a great way in which maybe a staff person may be part of the patient advisory council and can bring back to the rest of the team some ideas and thoughts about what patients are thinking about what they're doing in the practice. But again, beginning to put people in the same room together to have these discussions. Thinking about how new patient and family orientation to your practice might look like, using volunteers within your practice. There are lots of things that patients might be able to provide for you in terms of helping the practice function and become more effective. How many of your quality improvement teams have patient participation in the project? I would encourage you all to have a patient on your quality improvement team, and I think that the conversation changes. It's a great way of beginning to validate and to understand where the patient fits into some of the changes that you're making within your practice. And then also to think about how you might collaborate with community organizations and programs. This may include Alzheimer's Association. In our practice in Eugene, we invited the Alzheimer's Association would come to the waiting room once a week. They'd be available to patients and families there. We'd allow them to see patients and do counseling in the counseling room there. How do you engage and connect with school-based programs? within your practice? Are there ways in which you can have a better collaboration with them? And I see that there's also an advertisement here for the July 9th PCPCI webinar, where there will be more discussion with engaging patients and quality improvement initiatives. I did want to leave you, though, with thinking a little bit about what is patient-centric team care. And so what I've done here is I've taken what I think are the sort of 5 key team principles, and I've done a crosswalk about, well, how does that translate into being a more patient-centric team? Certainly, leadership is critical to be a good team, have a good team in practice. And I would encourage and emphasize the importance of a leader's role is to make sure that the patient's voice is heard. That leaders in the team may ask or even take on the patient role in discussions when there may not be patients in the room, but at least ask the question about, well, what would patients think about this change that we're trying to make? That in terms of a shared vision and a culture, that you begin to ask patients what it is that they want and welcome their feedback through patient advisory councils or patient surveys. But that patient-centric team care is one way in which you can do that. We know that relationships are critical in teams, developing good patient and clinician communication skills. You might even consider more formalized training about how do you talk to patients, how do you introduce yourself, how do you connect with patients when they're going through stressful periods of time. And those are really trainable events, and for many healthcare professionals and certainly staff, they've never had any training in terms of how to communicate with patients, but this may be something to consider within your practice. Roles clarity, understanding the patient and family role in our processes, in all care processes. Again, having patients on the QI team is a good way of making sure their voice is heard at the time of the discussion, but also you may just want to share a care process with a few patients just to test with them to see if this might work for them or whether there may be problems with that. And then finally, understanding that that everybody's on the same page about what they're trying to accomplish. Inviting patients and caregivers to participate in QI, but also publicizing your quality indicators and your quality measures, maybe using posters or quality boards in your waiting room, maybe a newsletter that illustrates what you're trying to accomplish. These are the goals of our practice, and this is how we're doing on it, and this is what we're going to do to improve that. So I'm going to come back to the Providence group here with that and have you talk a little bit about what you all have thought about in terms of what's worked well in working with patients and families and your challenges here.
Okay, this is Charlotte again. Our larger medical group has had a patient advisory council for some time, but we've decided as a clinic to pursue our own. So we're in the baby step stages of getting that put together. Our challenge, I think, with the patient advisory group is we have so many patients from that have immigrated in so many different languages. It will be a challenge to see how we get input from everybody. One of the things that we set out to do here that I'm quite excited about is we decided that we were going to help our patients set healthcare goals, and that we were going to do that by not putting it back on the provider to do, but by training all of our staff in how do you help a patient set a goal, motivational interviewing, and then how do you follow up in terms of health coaching to get them to accomplish those goals. So we're about 6 months into a 1-year pilot of this. Our behaviorists trained all of our staff and all of our providers, and we have our MA staff and our front desk staff, checkout staff, as well as our residents and providers all doing goal setting with patients, and it's been pretty exciting. It's a different way of engaging patients, and they've been a little surprised, so that's been our challenge. They're not quite sure what we're up to and what we're asking of them, but once they understand, it's just been a tremendously positive response.
Great. Other comments or thoughts there?
I was going to hand off to Zoila.
Okay.
Hi, this is Soila again. I was going to touch base on a different way that we try to engage patients with the whole team model. And we start with, at check-in, when an MA checks in a patient, we introduce that they're part of a team. We let them know who their team is. The front desk actually has handouts that have everybody in their team and their role that they give to new patients, so they know who we all are. When the MA checks them in, they reiterate that. Every time they are checked out in an AVS, the after visit summary, we have their team and who their care coordinator is, so they know who to get a hold of. And as a care coordinator, when I make outgoing calls, we leave a message to say, when you call us back, please call and speak with your care team, A, B, or C, whoever we are. And I think it was a challenge at first. Patients didn't know what to do with that, but lately, it's been really great. They actually call and ask for their teams, and sometimes specifically for the care coordinator, because now they're getting to know who their team is and how we can help them.
That's terrific. You actually have a sort of a brochure of the players on the team, and then connecting it to your roles and what the patient needs to do to connect with you. I think that's great. Other thoughts there? If not, I'm going to open it up to the rest of the webinar participants. Are there any other comments or questions for the Providence group? Which, by the way, thank you so much. You may not hear it, but we're clapping for you right here, as are the rest of the webinar participants. But thank you very much for sharing what you're doing in your practice and redesigning your practice. And as you know, this is a lot of work, and it requires work every day to do this. So that's really great stuff. So let's open it up to webinar participants. Any questions or comments? Maybe some other folks might want to share what you all are doing in some of these strategies.
So this is Kate. We have just a couple of minutes left in the webinar today, so I'm going to go ahead and say that right after the webinar you can complete a short survey, and no worries, you can access this recorded webinar along with all of our other webinars on the website, and there are slides already posted for those of you that are curious about that, if that's your question. But one question that came up for the for our guests, Providence Medical Group guests today, what are some of the ground rules that you came up with as a group? Just some examples. What were some of the themes that came up when you got together to make some ground rules?
Okay, this is Anna Marie, and I have our ground rules. We have them posted by those magnetic boards in each team area, and we every 6 months or so touch base and go over them again. A few of them is we agreed to open and honest communication with each other. The big one my team struggled with, but we overcame it, which was respecting the team meeting time. That means communicating with the team member if there's any reason for lateness. And again, that means also making it important that you arrive at the meeting on time and taking it seriously. And I, being a front desk person at the time, it was hard to reprimand or ask these doctors who weren't maybe seeing patients, but maybe ran to grab their lunch or something to please arrive, to the meeting on time. But we're there now, and it's amazing. Respecting each other, critiquing ideas rather than the person, and then any idea should be open for discussion. And I would say the one ground rule we agreed on as a clinic was to try any new idea or workflow change for 2 weeks. And then at the end of the 2 weeks, we come back to our teams and check in and say, how's that going? What can we do to make it better? And everybody is on board with that.
Those are awesome ideas, and I'm wondering if maybe you might want to share those, whether you'd be willing to share those. Obviously, these are examples that might be a little bit different for different clinics, but it might actually be helpful for maybe some of the other practices to see what were some of the ideas that you all came up with.
Oh, that's wonderful. We can share that, definitely. I think it's really important, and we've been, we're into this a year and a half into it, so we've critiqued them and followed them, and they've worked for all of our teams.
So it looks like there's about 1 minute left that we could take one more question if one of you could answer this. in just a short amount of time. What happens when someone new comes to the practice and they're joining a team? So what's the process to catch them up to speed on how all of this stuff works and how you work together?
Sure, this is Evan Salino, and yeah, so I'm fairly new to the practice actually within the last year, and actually being a residency practice, we have new folks come in, new docs come in, you know, every year as well, and right now we're struggling through having some team members move on for educational reasons and things like that, and so dealing with this is really important. One of the things, you know, just touring around the clinic, getting to meet everybody. Actually, when I first came here, I met every single person that worked in the clinic. There are pictures of everybody who works here by team everywhere, so you can actually put a face with a name, which is critical. And then really establishing, again, things like team rules and roles that are visually present everywhere is really important, and pointing those things out. Obviously, there's a process for everyone, but just establishing the culture, you know, as people are brought on, and again, putting faces with names and making sure that people feel welcome. But having a defined process is really important, and I think we're still defining that for ourselves.
Yeah, that's great. And so I think with that, we'll end the webinar today. And again, let me express my thanks, Evan, to the folks out at Providence Southeast Family Medicine for sharing the work that you've been doing out there. It sounds great, and I hope that you can continue to share with everyone else, because I think this is how change is going to happen. And you know, I really don't have anything probably profound to end this with, other than to say that encourage you all that continue to work at this. The teams just they don't just happen. That you really need to be deliberate about thinking about creating the infrastructure, creating the environment, creating the relationships that are necessary to provide a highly efficient and effective delivery of healthcare. And that, I know that many of you are leaders out there that don't underestimate the importance of what you do, that this is really critical. And lastly, this is really hard work, and it's not going to happen overnight. That this takes time. There are some resources. Certainly, the lessons from the National Demonstration Project has a number of talks about a number of things that we talked about this afternoon. Also, a little bit about the flourishing and joy of practice, and there will be some other documents online to support the things that we talked about today. So thank you very much, and best wishes to you all.